Bacterial survey. Part 3 will be its own third video, but they are the same set of slides. Okay. Also, I did make some updates to these slides. So last week I posted the slides, but I finally had a chance to go through all of them and make updates. Most of those updates are just to give you more information, more slides, instead of having you take the notes orally. So just trying to, since we're not in person, just trying to make them better for you for distance learning. And I have removed the old slides and replaced them with the updated slides. So it won't look any different in the module, but just go ahead and download those slides and replace them. If you are printing the slides to study, then you'll want to just print out the slides that I added. Look through the slides. There might be small changes here and there in addition to the slides that I added, and you could definitely just handwrite those. So I don't want you to feel like you need to print out a whole nother set of slides. Also, not sure if I ever told you guys, but when printing, I suggest you do no more than 4 slides per page. You can do it front and back if you want, but if you do anything smaller than 4 slides per page, it becomes too small for you to really see some of the images and things. So that's my advice. That's what I always in person tell everyone, to print them out 4 per page, bring them to class, and then write notes on them. I know things are quite different now that it's distance education. So however you choose to do it, I trust that you know by now, by a year of distance learning, you've probably figured out what works best for you. All right, I hope you've been enjoying learning about all these diseases. This is definitely why I became a microbiologist, because I find it so fascinating. Okay. So last time we looked at the alpha Proteobacterium. Now we're going to look at the rest of the Proteobacteria. So starting with beta. So beta Proteobacteria, the ones I've selected to talk about are Bordetella Pertussis, Burkholderia, and Neisseria. And Bordetella Pertussis is the causative agent. It's the bacteria that causes whooping cough. Whooping cough used to kill about 10,000 children in the United States every year before the invention of the vaccine. The vaccine is made up of cell fragments of the pertussis bacteria, so that your immune system can make antibodies against those fragments. And we call those fragments antigens. And then your immune system makes antibodies, so that if you ever come into contact with that bacteria again, you already have those antibodies ready to immediately respond, and you don't even know it. You won't have any symptoms. You won't get sick, and that's why vaccines are so amazing. Now, eventually, we'll probably be able to talk about the COVID vaccines, which are actually a new generation of vaccines, completely different than all of these current vaccines that you get as a child and as you grow up. Okay, so Bordetella pertussis, it is called whooping cough. It's highly, highly contagious. You may remember in the past 10 years, we've had a strange movement of people that we call anti-vacciners that have, for some reason or another, believe this false information about possible harm from vaccines, and so they didn't vaccinate their children, and we started to see outbreaks of things like whooping cough and measles pretty quickly, and I believe we did have some children die, and so I really cannot stress enough how safe vaccines are. There's no way for the vaccine to cause a disease like these genetic diseases like autism, right? It just doesn't work that way. And there's so much testing that goes into these vaccines. It used to take, 10, sometimes even more than 10 years to develop a vaccine. We have gotten faster at it, especially with this new approach that we have with the COVID vaccine. But it's definitely safe. Not to mention that you have to think about all of the countries besides us, and we have enough people as it is to have huge sample size, but we vaccinate billions of people, and if it wasn't safe, we would know, especially by now. So I believe the Bordetella Pertussis vaccine came out in the 1940s. So that's come on, there's no way that this is causing all these problems that people spread rumors about. Anyways, you can always go to the CDC. You might have to click around a bit, but when you get into the vaccine section, if you keep clicking more information, eventually you'll get to a huge PDF report where it will tell you every single vaccine. It tells you all the different test results, all the possible side effects, and the specific ingredients in these vaccines. And so it is public information, but it's not always the first thing you see when you go to the CDC, because they try to take these reports and put them into a more user-friendly kind of format where the general public, can get the information that they want about the diseases and things. So anyways, feel free to talk to me more about this in office hours, and I can even pull up the CDC and we can go through it together so you can see for yourself. Okay, so it's Bordetella pertussis is super contagious. We say it's airborne. Of course, we mean airborne droplets. So this is person to person. It is considered direct transmission, direct contact, because you do have to be in a close enough proximity to breathe in those droplets. So just like COVID, but with a much higher transmission rate. Right, so coughing, sneezing, and just breathing the same air, those are all ways to inhale the droplets from an infected person. Of course, as I mentioned, you can prevent this through vaccination, and you really need to prevent this through vaccination. It's really hard to get a diagnosis in time to get treatment, okay? So we say that you can treat this with antibiotics, but again, that's only if it's able to be diagnosed in time, and it almost never is. Okay, so this bacteria, Bordetella pertussis, has a capsule. This capsule will attach to the cilia that line the trachea, okay? And then 3 toxins, which, the bacteria is using these proteins to attach and colonize the trachea, and our body responds to these proteins as toxins. So it's not necessarily that the bacteria, that the goal of those proteins are to be toxins, but that's how they behave in the body of people. Okay, so these 3 toxins, once they're in the body, antibiotics are not going to help, right? Antibiotics will help kill the bacteria, but they won't get rid of the toxins. Of course, the sooner you get rid of the bacteria, the fewer toxins and the faster the person can start to recover. But it just isn't the same when you're dealing with toxins. The toxin is causing harm. So these 3 toxins are called the Tracheal Cytotoxin, the Pertussis toxin, and the adenylate cyclase toxin. Okay, so let's talk about each of those. So as I mentioned, the 3 toxins anchor the bacteria to the epithelium of the trachea, specifically on the cilia, and that's shown here in this image in the upper right corner. And so first you have the tracheal cytotoxin, which directly damages the cilia. And if cilia are not able to function, then you're going to get a buildup of mucus. That mucus becomes very thick. And that is actually what causes the airway to close up. Well, that's part of it. You also will have inflammation, which contributes to narrowing of the airway. This thick mucus is also what leads to these violent coughing fits, which can be so extreme they can break ribs. Of course, we're talking about children. They're not necessarily as, it's not going to be as strong as an adult. But it can lead to periods without any oxygen, which can lead to brain damage. Especially the younger you are, the more sensitive you're going to be, the less time you can survive without oxygen. Okay. The pertussis toxin can enter the bloodstream and cause issues that way. It will signal for a T cell population, which is a type of white blood cell. So basically it's telling these white blood cells to come to the infection, but then it doesn't allow them to get into the endothelium, out of the bloodstream into the endothelium where the actual infection is. So kind of cruel, right? And so this actually will lead to the swelling, having all these immune cells trying to get to the infection site and not able to. So you get the swelling there. You have the tracheal cytotoxin, which damage the cilia, and you get the buildup of the mucus. And so really it's these are the main two that are causing the whooping cough. When the person tries to get air right after the coughing, when they try to inhale, the airway is so narrow that it makes this whooshing or whooping sound as the air goes back into the lungs. The adenylate cyclase toxin also plays a role in infection. It blocks phagocytes from getting to the infection, and it can also induce apoptosis in those phagocytes. So they commit what we call cell death, cell suicide. So together, these three toxins are really nasty, right? Each one of them alone is terrible. Okay, so the vaccine that we give to children is called Dtap, and this is for diphtheria, a different disease that we'll look at, tetanus, and pertussis. So these we actually are talking about each of these in this survey of bacteria. Now, adults will want to have a booster because adults can also get whooping cough, and typically it's not going to give the most severe forms of death and brain damage, although it could. But one of the even more important reasons that adults need to be continue to get these boosters from time to time is so that when you're around babies who haven't yet had their vaccine, they're not old enough yet because their immune system's still developing, you would know that you're not going to give it to them because you're immune yourself, right? So that's the biggest reason for adults to get their booster. We also administer the booster when women are in their third trimester. So as the woman has this surplus of antibodies going through her system, they will cross the placenta and offer protection to the infant, and they'll last a few months, and then if she breastfeeds, continue to give some of those antibodies to the baby, and so this just helps also reduce the likelihood that the baby would get the infection while waiting for it to get old enough to have the vaccine. Okay. I think that's everything I wanted to say about this. Okay. So there are 3 stages of whooping cough. The first stage doesn't seem bad. It seems like a normal common cold, congestion, regular coughing, nothing alarming, and we call that the catarrhal stage. But then, as I mentioned with the toxins, you get the airway swelling, you get the buildup of the thick mucus, and so then you will, so it takes about a week incubation for the first stage to appear, and then about 1 to 2 weeks of having those common cold-like symptoms, then you'll go into the second stage, which is the paroxysmal, doubles there, phase. And so that can last anywhere from 1 to 6 weeks, depending on the extent of damage and the speed of being able to recover from that. This second stage is where you have the really severe, the onset of the really severe violent coughing fits. Now, this, when you're dealing with an infant, they might not be able to even have the violent coughing fit. They may just stop breathing altogether. Sometimes you hear them gasping for air, but you don't necessarily have the obvious symptoms of whooping cough when you're dealing with an infant. Which is another reason why it would be very likely for infants to die, not only because they can't go as long without oxygen, but you don't really have all the signs. You don't have the signs and symptoms to rush to the emergency room and get treatment until it's too late. So I cannot emphasize enough for everyone to get their vaccinations, and then as soon as the baby is old enough to have it, get its vaccination. And do not allow anyone around your baby that has not had their vaccinations. Okay, so it is quite common for mothers to keep their infants home until they've had all of their vaccines, and the doctors said that it's safe to be around people. Okay. Then you go to the convalescent phase. If you survive, you still can have these whooping cough episodes, but you are starting to, the symptoms are improving and the airway's starting to heal, and this could take 2 to 3 weeks before all the whooping cough actually stops. If it was suspected or you think you might have been exposed, you can get a nasopharyngeal sample where a swab is stuck up the nose and goes all the way through the nose to the back of the throat. Nasopharyngeal. So I put a link here on the bottom right, which shows the testing, what that looks like, what's involved. I'm not going to require you to look at that one. Just put it there for your own if you're curious. The link on the more left side is going to review everything I just reviewed with you, with a little bit of images, right? So that's just helpful for you to study. Okay. Next, Burkholderia is mostly nosocomial infections, right? Healthcare associated infections. It's a real particular problem with individuals that have cystic fibrosis. It's also a fascinating bacteria in that it can pretty much eat anything, right? So any solution, surfaces, like it will survive off of pretty much anything. It's been known to grow in solutions of cleaner. of certain disinfectants, right? So that also makes it quite dangerous, right? Because then it's hard to kill. There are different species. I will not test you on the specific species. I did just put it there for you to become familiar with it in case, since most of you will be working in healthcare settings, you might need to know about this in the future. And of course, we see that there is this particular strain that's known to cause more severe disease, and it's endemic to Asia and Northern Australia. So it's not so much of a concern for us yet, right? When things are endemic in another area, sometimes that means it's just a matter of time before it becomes endemic here. Of course, climate and other conditions will affect that, but that just seems to be the way of the world right now, since there's so much travel and exchange of goods and things. Diseases spread rapidly, right? Remember chapter 14? Okay, so possible biological warfare, when you have something that survives so well, can eat so many different things, that does give you a potential, but also because it can also infect livestock and people. So you could target the livestock to make a population starving, and also people who come in contact with that livestock can then get sick, and then you can start an outbreak that way as well. So that's also another reason why this is on our radar. Okay, beta Proteobacteria still. Our last example is Neisseria. And we're going to look at 2 species of Neisseria, and you do need to know both of these species and all the specifics, and I guess that would be pretty obvious because I have slides devoted to each of them. And in this upper right hand corner, I don't know what's happened to my mouse. Here we go. In the upper right hand corner, you see these larger pink, I'll call them circles, even though they're all kind of different shapes. Those are leukocytes. And then the smaller dark spots all around are the Neisseria bacteria. And so this is a smear from a sample of pus from a patient that has gonorrhea. Gonorrhea, as you know, is a sexually transmitted infection. What you might not know, I showed you pictures of Neisseria meningitis with the nice huge capsule, and they're both diplococci, but the Neisseria gonorrhoeae, which causes gonorrhea, does not have the capsule, but it is still a diplococci bacteria. So you typically, and I know it's really small, but you'll see that these bacteria tend to always be in pairs. If you do see an individual one, that can be for a couple of reasons. You're only seeing one dimension, so maybe if you were able to rotate the sample, you would be able to then see its other the other half of it. The other possibility is that in the process of making the smear, maybe they got detached. But the vast majority you will see in pairs. And so when you do microscopy work, you always have to look at the whole picture and try to find the pattern, right? Don't focus on the one outlying example. Okay, Neisseria meningitis, I spoke to you a little bit about before. We're going to look at it with more detail now, but it is the most common cause of bacterial meningitis. And so both of these are severe diseases, very significant diseases caused by the genus Neisseria. Okay, so for gonorrhea, the word actually means flow of semen. So rhea means flow. So like diarrhea means flow of feces, right? Gonorrhea, I guess the first person to study it didn't seems weird to me, but didn't distinguish the difference between pus and semen. So it actually means flow of semen. And perhaps that's also a jab at the fact that it's a sexually transmitted disease. But it really should be pus. Okay, so anyways, any mucous membrane can become infected. So the most common areas of infection would be the male urethra and the female cervix. But if you're having anal sex, the mucous membranes of the rectum can become infected. If you were to have touched the bacteria and then rub your eye, you could get an eye infection. Oral sex, you can infect your throat, right? So any mucous membrane can become infected with the gonorrhea bacteria. Okay, specifically, the gonorrhea bacteria attaches to, like I said, oral or urogenital, any mucosa, using its fimbriae. Remember, fimbriae are like those hair-like projections, but I refer to them as fingers because they're really good at grabbing on to surfaces. And so the mucosa is one of those surfaces that it grabs onto with its little fingers, okay? The fimbriae. It also has these special proteins on its surface called OPA proteins that prevent proliferation, which like division, increase of CD4 T cells, which are a type of white blood cell that play a crucial role in being able to make antibodies. So you will not develop immunity. You can keep getting infected. Like if you get treated and you're cured and you go back to that same partner, if they didn't receive treatment, you can get it again. You can keep passing it back and forth. So that's something also to keep in mind. It's why it is really important that when you find out you have an STI, that you do tell anyone that you had any sexual activity with, so that they can get checked out themselves and not suffer from complications of these diseases. So another reason why this can be such a serious disease is that it's usually asymptomatic, especially for women. Men tend to, if they do have an STI, they are more likely to have symptoms. The most common symptom is painful urination and or the presence of a discharge of pus from the urethra. It could be any color. And then sometimes also like a pain or swelling of the testes or scrotum. Okay. Women, on the other hand, don't necessarily have any symptoms, and if they do, they're not like obvious gonorrhea symptoms, right? It could just feel like a UTI, or just an irritation. It could feel like a vaginal infection that maybe you try to treat yourself thinking it's nothing serious, and then the symptoms go away, and you never get checked out. Meanwhile, it's actually still there. It can move up into the ovaries and cause a pelvic inflammatory disease, which can lead to not only serious pain, lifelong pain, but it can also make you become infertile. It can cause scarring, and the scar tissue can interfere with the normal function of the reproductive system. So all of the sexually transmitted diseases are always they're most dangerous, I would say, for women because of the likelihood of it not getting treated and becoming a more serious issue like pelvic inflammatory disease. Okay. Gonorrhea, 60% of all infections occur between the ages of 15 and 24. And this is why good education is so important, and also good programs that provide condoms and things so that youth and young adults can practice safe sex. If we can make this something really accessible, without shame and embarrassment, that where people will actually utilize the resources, then we can really change this. And with that, that means you also need to be going to the doctor and having regular screening, as well, right? And so you need to be able to afford those doctor's visits, in addition to everything else, right? So 80% of men actually do develop symptoms, and men only have a 20 to 35% chance of infection, with their first exposure. Of course, each exposure after that, then it changes, it increases, and there's no concrete number for me to provide to you. But what I want to contrast that with is that a woman's first exposure to gonorrhea, she is 60 to 90% likely to actually become infected. So that's another problem with STIs, is that women have such a higher risk of actually becoming infected upon exposure. And then they have fewer symptoms, so they're less likely to get treated. It's very sad. Okay, if left untreated, it can be quite serious. It can result in dissemination. It can get into the heart, cause endocarditis. It can get into the central nervous system, cause meningitis. It can get into your joints and cause arthritis. And it can also, if you have this while you're pregnant and you deliver, it can cause blindness, to the baby. Okay. Also, because this has been around for so long and it's so common, we now have to treat it with 2 antibiotics, because it is likely to be resistant to at least one of the antibiotics. So we give 2 different categories of antibiotics to ensure that we do treat it, and that also helps to prevent further development of antibiotic resistance. Okay. Here it's pretty outdated now. It only goes up to 2008. I think if you have the current edition of the textbook, they may have updated that to at least 2014. So I need to update my slide here. You can see, as much as I update my slides, there's still always more to do. Okay, so the percentage of resistance, so we see these different types of antibiotics, and we see, the first kind of year that we started testing for resistance, 1988. This doesn't mean that's when resistance actually started, but this is when our graph starts. And we see tetracycline, which is a good antibiotic, good strong antibiotic, there's a big increase, in 20% of these infections were resistant to the tetracycline. And we started to see penicillin resistance. And by 1998, 10 years later, we see that the penicillin resistance has increased about 16-17%, and the tetracycline increased, not too drastically, not compared to penicillin, but it did increase to over 20%. And now we have this third type of antibiotic resistance, which is azithromycin. These are the 4 groups of antibiotics to treat this infection with. Now we see in 1998 that 3 of them are not necessarily going to be useful, right? And then in 2005, we see all 4 of our antibiotic groups, there are resistant strains of gonorrhea. And look at azithromycin, just through the roof. Over 35% of all infections are resistant to azithromycin. So we had to stop using it, and we had to start using 2 of these different antibiotics in conjunction. And that did work. Look, we got the azithromycin resistance down, but we also now have tetracycline even higher, and fluoroquinaclines are now also higher. So it's an ongoing struggle. We have to monitor it. We need to be careful how we are prescribing antibiotics. We need people to also use them as directed. So a current approach is to get a high dose injection with one antibiotic type, and then the patient doesn't have to follow any instructions. It's done. And then you give them one prescription that might only be about 5 days, and they're more likely to be able to follow through with taking it for 5 days. And so this is the current practice for gonorrhea and syphilis and chlamydia. Also, if you have gonorrhea, you're more likely to have chlamydia, and you're more susceptible to other sexually transmitted infections once you have one. Okay. All right. So now the other Neisseria bacteria, called Neisseria meningitidis, because it can cause meningitis. And because this is such a distinguished and severe disease, it actually has gotten its own specification as being called meningococcal meningitis. Meningitis, as you recall, means swelling of the meninges, the tissue that covers the brain and the spinal cord. And this is very life-threatening, okay? So highly contagious, spreads through saliva and aerosols, so kissing, sharing drinks or food, as well as close proximity aerosols, droplets, right? Okay, very quick treatment is important. It's highly fatal, and those that do survive can have permanent disabilities such as amputations, nerve, brain damage, right? Very, very serious, okay? If you ever have you wake up or at any time during the day, you have a stiff neck where you cannot bend your head towards your chest, and you have any other symptom, like a fever, a headache, any other symptom, nausea, anything, you have a stiff neck with any other symptom of being ill, you go straight to the ER, urgent care, whatever, you get treated immediately, okay? Also, there's a vaccination now. This vaccination, typically in the United States, there's a strain, and I believe it's a serotype B, that the vaccination doesn't cover, and that's because it's not as common in the United States. So if you're traveling, you may want to ask your doctor about getting full coverage. It might be a different vaccination that covers all the serotypes, or you might need to get 2 different vaccinations, but definitely talk to your physician about making sure that you're fully covered. Okay, this is pretty common in colleges, dormitories. It can also be common in other close proximity living, like a military, or even penitentiaries. Okay. It can also cause a blood infection, but that's it's almost, I'm hesitant to even talk about it because, like, I don't want you to miss the point that, if it gets into the central nervous system and causes meningitis, that's our main concern. That's the life-threatening, very, very fast progressing infection that we're trying to prevent with this vaccination. However, the blood infection's also serious, right? If it were to get into your blood, right, bacteremia means bacteria in the blood. But it can actually cause a blood infection, which would be septicemia, actually having the blood be infected. The bacteria grows in the blood, okay? And by grow, I mean divide and multiply. Damaging to the walls of your blood vessels and causing bleeding. And the bleeding's internal, but sometimes can also be seen on the skin. As the blood vessels are damaged, it can make a rash. And this with this blood loss, you can have like these cold hands and feet, cold chills, severe pain, fatigue, vomiting, muscle joint pain, abdominal pain, right? All sorts of symptoms that you can have. And like I mentioned, the rash, it will become darker and more obvious the more, the later stage, of the longer the infection goes on. Okay, so if meningococcal disease is suspected, this first, the meningitis, the getting into the central nervous system, antibiotics would be given right away because you need fast treatment. In the meanwhile, once you are hooked up to this antibiotic IV, then we can move on to the testing to confirm. And if it was negative, then you would just be taken off those antibiotics, okay? But antibiotic treatment should reduce the risk of dying, but it does not guarantee that it will treat it in time to prevent the permanent damage to the body, right? So even with antibiotic treatment, about 10 to 15% of cases are fatal, and about 11 to 19% of survivors will have long-term disabilities. It can be anything from one or more limbs having to be amputated, deafness, severe nervous system problems, or brain damage. So this is one of the most severe diseases that we're talking about in this class, right? It's so fast, right? As once it gets access to the central nervous system, it just destroys you, okay? Get vaccinated. Tell everyone to get vaccinated. So how do we test it and confirm it? Well, we would take a blood sample, see if there's anything going on there. And then we would also have to take a lot of people call a Spinal Tap. And this is a specialized procedure, so only a trained physician can do this. But you insert a long needle called a spinal needle through between the vertebrae and get all the way into the spinal column and take fluid. And as you know, our spinal fluid should never have any microorganisms in it. But we would both look at the sample under the microscope, and we would culture it as well to see if anything grows. And we would also do the same for the blood test that's taken as well, just to get an idea of what's going on. Okay. All right. So now we're going to look at the next group of Proteobacteria called the gamma Proteobacteria. So everything we've been talking about for part 1 and now part 2, still gram-negative. So here we will look at a lot of organisms, but not necessarily in all the detail that we've been seeing so far. And I did put some notes here so you can get an understanding of the classification, but I decided with how many organisms we're dealing with and in kind of a short amount of time, I am not going to test you on all of the classification for each organism. You definitely need to know the genus name. If I gave you a species name, you need to know the species name. You should know if it's Proteobacteria, but I'm not going to ask you the class, right? So you need to know the phylum, the genus, and the species, but I'm not going to test you on the class or the order. But I do want to show it to you so you can at least get used to the naming system and utilize it if you need to, okay? All right, so Pseudomonas aeruginosa, I also had mentioned this in a previous lecture before. It is unique in that it has this rapid efflux pump system. And what that is that as soon as the antibiotics get into into the cell pumps it right back out. And that can be true for disinfectants, any substance that it doesn't like, that it doesn't want, it pumps it right back out. So it's incredibly difficult to treat infections with Pseudomonas aeruginosa. Thankfully, Pseudomonas aeruginosa is an opportunistic pathogen. So all of us that have, healthy immune systems are not walking around worrying about getting an infection with Pseudomonas aeruginosa. It's also not typically community acquired. Rather, it's typically a healthcare associated, and it also makes up a large amount of healthcare associated infections. 1 in 10 healthcare associated infections are Pseudomonas aeruginosa. That's huge. Okay, people most at risk, burn patients. They've lost their barrier, right? Their skin is not healthy. There may be regions where it's missing altogether, but it's damaged. So you can see how that would be a huge risk. Cystic fibrosis patients are also at risk. Their lungs, right, are compromised. They have thick buildup of mucus. And anyone else who's immune compromised, which would be most people that are in a hospital for one reason or another, they're not doing well, and they're now susceptible, and they're in a place where there are a lot of germs. Okay, this is an opportunistic pathogen that can pretty much infect any tissue that it gets access to. So it can cause a urinary tract infection, and in hospitals, if you're on a urinary catheter, you have a great risk of developing a UTI. Skin infections, if it gets in the blood, it can also infect the blood and the lungs, right? So it is also metabolically diverse, meaning that it can survive on different types of food sources, as well as surviving different environments that we see here. Like the urinary tract is a very different environment than the skin and the blood and the lungs, right? So that's very diverse. It can also form biofilms on surfaces, not in the body, but on surfaces. So anything artificial in the body, and then surfaces outside of the body as well. Okay, so it has a diverse range of environments it can survive, temperatures as well. So grow in a wide range of temperatures, anywhere from a refrigerator, which is quite cold, to body temperatures. So that's a huge range. Usually these pathogens that we look at, if you were to stick them in the refrigerator, they would not die, but they would stop growing. It's like pushing a pause button, right? But not Pseudomonas aeruginosa. It'll just keep going. Your textbook has a nice description of Pseudomonas aeruginosa. You could definitely take a look there. A lot of these diseases, they will either be in the Survey of Bacteria, Chapter 11, or they will be in, if it's a respiratory infection, I think Chapter 24 is the respiratory system. We also have 25 and 26 digestive system and urogenital system. So you can always use your textbook to kind of see it, how they present it to you as well. Okay, another, so remember gamma Proteobacteria. Legionella is a bacteria that causes Legionnaire disease. And this can be found in nature, in streams, It can be found in our water systems. It can be a warm water or a cool water system. So it's really good at surviving in any type of fresh water. Okay. We are suspecting that it might also survive in swimming pools, but I cannot confirm that right now. Okay, so transmission, you have to inhale the aerosols. Turns out if your water tank has this and you're showering, that will aerosolize and you will breathe it in that way. The first known outbreak and how it got its name is that there was a swamp cooler, and there was a reunion for retired military people, and they just had a huge outbreak of pneumonia. Each year, it's estimated that 10 to 20,000 people become infected with Legionella bacteria just in the United States alone. And it's not uncommon for patients with Legionnaire's disease to be admitted into an intensive care unit, right? Very severe pneumonia. Also, interestingly, once you've cured them from the actual infection, they can suffer long-term impairments and a great reduction in quality of life. We see about 75% of recovered patients struggle with fatigue, ongoing fatigue, neurological symptoms in about 66% of patients, and neuromuscular symptoms in about 63%. And this is looking several months after the infection. Okay, I don't know how long those symptoms continue on, but it sounds like it is pretty long term. So it is pretty serious. And of course, pneumonia is life-threatening. You can die from pneumonia. And of course, the older you are, the more likely you are to develop a severe form. And so we do see that this is often lethal. And then, as I mentioned, those that survive, it can be quite difficult for some time. It's best to do serological testing. So you take samples from the patient and you test it with antibodies. So serology is the interaction of antibodies and antigens, which is great because it's very, very specific. And it'll tell you if they have that specific disease or not. We can treat it with beta-lactam antibiotics, which you probably have heard of penicillin, right? So penicillin is a beta-lactam antibiotic. It targets the cell wall, the building, the synthesis, the linking of the cell wall. So the cell wall becomes weak and then it lyses open under the normal osmotic pressure. Okay. Vibrio Cholera, we've talked about a lot already in this class, but now you get to see it a little bit more specifically. So it can really thrive in alkaline environments like lagoons and seaports. The number of infections and deaths due to this infection keep increasing every year. So even though we tend to think of this as like an old disease, it's still around and it's still very problematic. It is spread fecal-oral route, but interestingly, in addition, we also can see it surviving in coastal seawater. Of course, that seawater would have been contaminated through the fecal-oral route, but then it doesn't. The seawater doesn't kill it, as you would suspect it would. Then you can have shellfish that end up having that bacteria, and if you eat the shellfish, then you can become infected that way. So now you have an additional transmission route. So feces of the infected person or animal gets into the water, and then you either contact the water directly or indirectly through like the shellfish, right? In addition to the regular thing of routes of like fomites, right? People who are infected and don't wash their hands touch doorknobs, you touch it, then you eat something, or you rub your eye or whatever. So all of those normal fecal oral route transmission pathways, but now we're also adding the seawater component and eating contaminated sea creatures. Symptoms are, as you know, the gastroenteritis symptoms, but also because it is cholera, you have a cholera toxin that causes extra profuse watery diarrhea, which can lead to super severe dehydration in just a matter of hours, and that is why it's so lethal. So, of course, treatment's rehydration therapy, but sometimes if a person doesn't seem to be recovering on their own, antibiotics can be given as well. Diarrhea itself kills over 760,000 children under the age of 5 each year. That's not even including. So this number of 760,000 children is only children 5 and under. The number would be even greater if we extend that age out. But the idea is to show you that 5 years and under are the most vulnerable, right? They're the most at risk of dying from dehydration. Over 120,000 cases of death, of diarrheal death, is specifically Vibrio Cholera. It's another reason why it's really important to have a strong wastewater treatment system and freshwater treatment system, so that people are not contaminating the seawater, for example, with their waste, but it's properly being disposed of, keeping all of our waters free of contamination. Okay, continuing on, we have a group called the Enterobacteriales. This is a group of enteric pathogens. Remember, enteric means intestinal and digestive tract, right? So we're talking fecal oral route transmission, we're talking contaminated water and food and fomites, right? All of these in this group have remember the distribution patterns of flagella. So peritrachus is peri-hairy, meaning that they have flagella all around, not just at one end. And then they are facultative anaerobes, which makes sense. You have to be at least facultative anaerobe or obligate anaerobe to survive the gut. So if you're facultative, that means you can survive the gut and outside of the gut. If you're obligate anaerobe, you're only going to grow like in the gut or some other anaerobic condition. Okay, anaerobic without oxygen. Okay, if you're an obligate anaerobe, oxygen might be lethal to you, but you definitely cannot use oxygen. Bacilli, rod-shaped. Okay, so these are the characteristics that you would want to remember for the group called Enterobacteriales. And these are examples of this group, and there's this one exception, Yersinia pestis is not a perfect fit for saying fecal oral route, but the rest of them are. So let's go ahead and look. And if you haven't gotten the idea yet, hopefully you do now. That is super, super important to have proper hand washing every time you use the restroom and before you eat. Okay, so Enterobacter is a big group, lots of different species. It can cause a few different infections. It can get into the skin, cause a skin infection, lower respiratory, lungs, UTI, right, urinary tract infections. Of about 75,000 gram-negative organisms collected from ICU patients in the United States, between the years 1993 and 2004. About 13.5% of those were an Enterobacter species. So again, this is a huge, is a very significant group of organisms that are causing critical care patients, right? We also are seeing multi-drug resistance increasing in these species. So most of the Enterobacter infections are healthcare associated, and it can cause bacteremia. It can get into the blood. It can disseminate. Okay, it is a facultative anaerobe, so it can survive with or without oxygen. And there's also kind of a bizarre relationship that we don't quite understand yet, but there might be there seems to be a correlation to this organism and obesity as we continue to study and learn more about the gut and the microbiome. We will hopefully have more answers to these relationships. This organism's everywhere in nature. Soil, water, sewage, it's everywhere. Okay. Shigella is important. It has these toxins called the Shigella toxins, and it starts out as one toxin and it can split into two, so A-B toxin, and it causes dysentery, so bloody diarrhea, but it's also pretty watery as well, so it's very severe. So Bacillary Dysentery, it means it's a rod-shaped bacteria that's causing bloody and watery diarrhea. You can have vomiting, abdominal cramps, gas as it grows and divides and metabolizes. It releases gas, so you can get a buildup of gas. Of course, fatigue, and the fever is a low grade fever. It could be anywhere as soon as 1 day after exposure, typically 3 to 4 days. And it could take as long as 10 days for these symptoms to occur. And what we see, and the other reason why it's of significance to talk about, is that we now have a few different strains of E. coli that are pathogenic, and it's because they got these genes from Shigella. So Shigella had these plasmids for these toxins and shared them with E. coli, and so now we have strains of E. coli that are pathogenic. And these, both Shigella and the pathogenic E. coli, can be life-threatening, not only for the regular reasons of diarrhea being life-threatening from severe dehydration, but the toxin can also affect your kidney. Your kidney can become infected with the bacteria, and you can develop symptoms from that. And it can be, a kidney infection is always serious. It's a vital organ, and if you damage it, there's no guarantee that you'll recover from that damage, right? The symptoms of the kidney infection, if the kidney infection does occur, typically are 7 to 10 days after the initial onset of symptoms above. I don't want you to be afraid of E. coli in general. Most E. coli is non-pathogenic. We consider it good. It helps make vitamin K for us. All sorts of really good interactions in our gut. We need it. Okay. But when you get the pathogenic type of E. coli, then it's very dangerous. And that's why we've had these recalls of spinach and tomatoes and all sorts of different things from time to time. Typically what happens, the irrigation water has become contaminated by animals that have the pathogenic strain, and then it gets onto the vegetables that way. That's usually how these outbreaks happen. It's not the only way, but that's the most common. Okay, so It's not just people that can be infected, right? It's any warm-blooded animal. The symptoms often begin slowly and mildly with pain and discomfort in the belly and regular diarrhea, and then it continues to get worse over several days. Around 5 to 10% of people who are actually diagnosed with a pathogenic E. coli infection develop the potentially life-threatening complication known as hemolytic uremic syndrome, HUS, and that's the kidney infection. Okay, clues that a person is developing HUS include a less urination, right? So a decreased frequency of urination, which is, I want to point out, the opposite of most UTIs, right? UTIs, you'll have frequency and an urge to go even if you don't have urine. Well, when the kidney is no longer able to function, you just cannot produce urine. So you're going to have a decreased frequency in urination. You're going to feel extremely tired, and you can even start to lose like the pink colors in the cheeks, right? You visually start to look ill. Okay. A person with HUS should be hospitalized. Their kidneys can completely stop working, completely shut down. And then, of course, if your kidneys completely shut down, then that's lethal, unless you get put on dialysis quickly enough. Of course, we also want to treat this infection so that the kidneys don't become permanently damaged. Some people will suffer permanent damage, and some people will die from this. Children seem to be more susceptible to this HUS than adults, but it can. We do see adults with this. All right. So, continuing with our talk about E. coli, it makes sense to talk about urinary tract infections. So now with the regular good E. coli in your gut, if it gets into your urethra and is allowed to travel up, meaning if you're not having frequent urination or for other reasons you are vulnerable, you can have a bladder infection, cystitis, right? So I mentioned how this is different from HUS with the pathogenic E. coli in that typical UTI infections, or cystitis in particular, would be a frequent, urgent feeling of needing to go, but not necessarily being able to. You can't produce urine that quickly necessarily. You've already gone and emptied your bladder, and then, you still feel like you need to go. And typically also it's painful, burning feeling when you do try to urinate or when you do actually urinate. You may or may not notice that your urine looks different. It could look cloudy, but because we urinate into toilets, it's not always obvious. So, of course, if you have difficulty, painful urination, you should go to the doctor. If maybe it doesn't hurt, but you feel like you're having to go often, then that would also be cause to go to the doctor. They'll take a urine sample. The urine sample, they'll do a little dipstick test to test for leukocyte enzyme. And then they'll also take that sample, grow a culture. If you grow 100 colonies or more, that would be a confirmation of that bacterial infection. But if you have a positive LE dipstick test, they'll give you antibiotics right away. You shouldn't have a huge amount of leukocytes in your bladder and being active, right? So that would be an indicator of infection. And of course, we confirm it with the culture. And you've probably heard me say it before, and I'll say it again. You should also always make sure that the culture is tested for, will the antibiotic you were given be effective? Is the bacteria susceptible to that bacteria? It turns out that sulfa antibiotics tend to be really good at treating urinary tract infections, but there are other types of antibiotics that can be used. And again, prevention, drinking lots of water, urinating often, as needed, and other good hygiene practices that I've talked about before. Okay, pyelonephritis is when the kidney, one or more of the kidneys, becomes infected. And again, this is also usually E. coli, because E. coli can continue to travel up from the urethra, up the bladder, up the ureters, and into the kidney. Okay. So especially if you have a cystitis, bladder infection that you don't treat quickly enough, or you just don't treat it at all, then you definitely could end up with pyelonephritis. Sometimes you can have a kidney infection that didn't work its way up, right? Rather, it got into the blood and then gained access to the kidneys, such as the pathogenic E. coli that I talked about. It was in your gut and then disseminated from there. And there's also another example we'll look at in just a second. But the vast majority of these infections are actually just normal E. coli that worked its way up your urinary tract. Also, it's interesting, we show it's a man here as the example, just to show you where your kidneys are located. But men are not commonly having urinary tract infections. Remember, it's much more often females. If you do have one or more kidney infection, it usually causes quite a bit of pain. The pain is not always like exactly where the kidney is located. It can be what we call flank pain, anywhere in the band. So imagine where your kidneys are, and imagine wrapping a band all the way around your torso. Anywhere in there can have pain, okay? And when you take, and usually you all have a fever and you'll be very tired. If you take a sample for culture, you're going to be looking at something of 10,000 or more colonies on that petri plate, on that culture. So much more massive amount of bacteria in the urine, as well as a very positive, immediate, very positive LE test, of course. Your immune system's trying to stop this infection. We're not usually good at treating ourselves. Our immune system's not usually good at stopping this. You do need antibiotics, and you need a good, strong antibiotic, such as cephalosporin. But again, get that culture, get the antibiotic screening to find out what the best antibiotic for your specific infection is. Okay. For all sorts of reasons, doctors do not always test that the antibiotic they give you is the right antibiotic. Some are very good about always doing that. Others are not. So make sure that you request it when you are working in the clinical setting. Suggest it if the doctor didn't order it. Like, I don't see the such and such test on here. Do you want to add it? Okay. So now, so I maybe I took out the other example. There is a unique organism that can be transmitted fecal oral route and then infect the kidneys. And maybe just because we have so much going on, I took it out. Or maybe, let me just see. Is it in here? I have a lot of different versions of slides over the years, and I can't always remember everything. But it looks like I took it out, and we won't be talking about it. Okay. Oh, well. It's a survey. I never said that I would cover every single thing, right? All right. So Salmonella, I also started talking to you about Salmonella before, and I told you that we have Salmonella typhi, which causes typhoid fever, and then we have the other types of Salmonella, most commonly, you'll see here Salmonella enterica, but it doesn't have to be Enterica specifically. There are other species as well of Salmonella. So pretty much it's either Salmonella typhi, which causes typhoid fever, or any other Salmonella type, which would cause salmonellosis or just regular gastroenteritis. Okay, so practically all Salmonella species are pathogenic, and they're usually normal microbiota of chickens, poultry, right? Salmonella species are among the most common cause of foodborne illness. We have a lot of tests for them since they're so common. So biochemical tests and serological tests for rapid identification. We look for markers on the cell, such as specific antigens on the capsule, on the cell wall, and on the flagella. We call those K, capsule antigen, O, and H, right, cell wall and flagella antigens. We also do the same type of screening for pathogenic strains of E. coli. We are looking at the KOH antigens to diagnose. And some strains will be named after one or more of these antigens. Okay. So typhoid fever caused by Salmonella typhi. There actually is a vaccine. We don't give it regularly because this is not an issue in the United States anymore. But if you're going to be traveling, you should inquire about it. If you're going to a region that might not have like safe, reliable drinking water and wastewater treatment. So it is fecal-oral route transmission. But the bacteria will also spread throughout the body in phagocytes and eventually be released into the blood. Okay, 1 to 3% of people who recover from typhoid fever actually become long-term carriers, and typically this is from the gallbladder being the reservoir. So only a small amount of people will be carriers, but it's enough to, as far as we know, humans are the only reservoir. So 1 to 3% of all infected people become the reservoir, and it continues to exist for this reason. Okay, so we do have the potential to eradicate this if we could get in the endemic regions, if we could get everyone vaccinated, we could completely get rid of this. It is highly fatal, 20% mortality rate, and most of these deaths are from an ulceration, so bleeding, internal bleeding. So this is still killing thousands of people in areas with poor sanitation. And if you're going to one of those areas, you should definitely get the vaccine, protect yourself. So here's a breakdown of the differences between regular, what I tend to think of as regular Salmonella versus typhoid fever, Salmonella typhi. Okay, so Salmonella enterica infects the large, you need a large infectious dose. You have to consume a large amount in order to get infected, but that, that sounds like, oh, good, I'm not going to worry about this, but it's easy to get a large infectious dose when you're working with poultry and things. Typhoid fever, on the other hand, you don't need a large infectious dose. Regular signs of gastroenteritis, nausea, vomiting, diarrhea. Very rarely do you get any serious very, life-threatening infections, but about 1% of infections will be, septic shock, very serious, right? Gets into the bloodstream. Infants and elderly are the ones at the highest risk of developing septic shock. Typically, you just have mild fever, nausea, vomiting, diarrhea, right? And it is an actual infection, but the bacteria also have an endotoxin, okay? We would need to isolate from a fecal sample and perform serotyping to diagnose that it is specifically Salmonella. And usually we just focus on oral rehydration. We don't typically give antibiotics for this. It can be 12 to 36 hours after ingestion of the bacteria before you get the onset of symptoms. You need time for the bacteria to actually start to colonate the gut. Symptoms anywhere from 2 to 5 days. So a little longer than our regular, when we think of things like food poisoning, it's usually you just 24 hours, you just have to flush out the toxin and you're done. When you have an actual infection like Salmonella, you're looking at a longer time frame of about a week of the full-blown symptoms, and then it could take you a few days to get back to feeling normal after that. Typhoid fever, on the other hand, you get a very high fever, you have a constant headache, and you also have diarrhea because it's colonizing, infecting your gut. And as I mentioned before, 20% mortality rate. It's a true infection. It also has an endotoxin, and it would also need to be isolated and serotyped and then treated with antibiotics. There's 2 types of antibiotics, the quinolones and the cephalosporins. Both can work. This is a long incubation time, about 2 weeks, and it's also a long illness of 2 to 3 weeks of symptoms. We didn't always have antibiotics, so you know that 20% mortality, so about 80% of people will recover on their own without treatment, but we don't want to take that risk. Okay, Klebsiella, not too much to talk about here, but when you work in the lab, it comes up a lot. It's an opportunistic pathogen. It can cause pneumonia, UTI. It can also infect the blood and the central nervous system. It does have a capsule, but it is not motile. You can find it in the environment, in soil and water, but you can also find it in people as just part of their normal flora. It can grow on blood agar, which is very unique. Only a few organisms have that ability. And it does appear to be rounder and thicker than other members of this group of Enterobacteriaceae. Yersinia pestis. This is the one that, though it is still a member of the Enterobacteriaceae, it doesn't behave exactly the same because now we have a more complex transmission route. So rats, rodents that have fleas, the flea bites you, and that's typically the transmission route, but it can also be spread human to human through aerosols. So it really depends on the type of infection that we're talking about. So if you look at the bottom, I have given you an example of Bubonic Plague, which is an infection of the lymph node, and that's actually what you're seeing right here is a huge a lymph node, infection of the lymph node. You can have septicemic, not I don't want to say not as common. I think it's not as common. Yersinia pestis is most famous for Black Death, Black Plague, or just plague, right? So there was Pneumonic Plague, and there was a Bubonic Plague. Bubonic is for the lymph node, and pneumonic obviously is pneumonia. This is an X-ray. It should be mostly black and white like you see on the top here, but instead we're seeing a lot of white, the majority of this X-ray. So all of that white space is fluid in the lungs, right? The alveoli. Okay, so you know of the Black Plague is killing millions of people in Europe during the Middle Ages. Now it's really not something to be so scared of because we can easily treat it with antibiotics. But of course, not everyone in the world has access to antibiotics, so we're spoiled in the United States. So the last occurrence of an urban outbreak in the United States was 1925 in Los Angeles. Part of the reason why we don't have these outbreaks anymore is because we know that rodent control is important. Okay, so we try to, we take a great effort to keep rodents out of the places that we live and out of the places that we eat, right? We also try to prevent and treat flea infections of our pets, right? So we have pretty much just stopped the transmission, our exposure at least. Humans can also, as I mentioned, directly spread it from person to person, like if it's the pneumonic plague, right? If it's in the lungs, you can, it will aerosolize and you can spread it from person to person. Also, if you were to just come into direct contact with an infected rodent, and you contact any of their infected fluids, you can get infected that way. The pneumonic plague is believed to have originated from cats that had infected fleas. I don't know if we know that for sure. The bubonic plague, the black plague, is from rodents and fleas. And as I said already, that this is showing the infected lymph node. All right. So that is the end of part 2. I will make a third video for you right now, actually. All right.